this week on the BackTable Podcast.
Just as far as tips and tricks go, now enough people are doing it that you can get advice and recommendations from a multitude of people. And everybody that I talk to does it a little bit differently. I think one big difference, is a lot of people do retrograde pedal approach. And I think for the PAD experts out there, that's an easy sort of a transition to do that. And obviously patients probably prefer that as well. For me, I've found that the anatomy is a little more difficult and a little more complex to come that way. But again, I think I encourage people to sort of talk to people to figure out what angles work best for them.
Hello, everyone, and welcome to the BackTable MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com.
Hello, everyone. Welcome to the BackTable Podcast. Today, we got another very special episode. Today, we're going to be discussing genicular artery embolization procedure with Dr. Osman Ahmed. Oz this is third time on the show. For those that missed the first two, Oz was on about a year ago, I think, on the Innovation Show where we talked about Flow Medical, right?
Yes, correct.
And then the second one, not too long ago, where we talked about upper GI blades, which is also a fantastic embolization episode. GAE, we've covered it a number of times in the past with, Jafar's been on, Bagla's been on, Ari's been on, but it's been a while since we actually have never really covered the nitty-gritty details of the procedure itself and sort of how somebody goes through it. And I actually got to see another plug for Guest MSK. We've plugged it a number of times recently, but I actually got to see Oz present on this at Guest MSK in Paris this last January. Again, great conference. Mark Little was on the show recently to talk about MSK embolizations as well. He talked more about the data behind it. Great to have you, Oz. Thanks so much for coming on the show again.
No, thank you, Aaron. It's quite the privilege, quite the honor to be on here, and third time's a charm. So let's do it.
That's right. And the other great thing for the audience who's maybe listening to this audio, we're actually going to have some video version of it as well. Well, some video. I was going to be showing some video cases. We'll put those out on YouTube and as well as on BackTable Plus. We're going to go over anatomy as well. So Oz, for those who don't know you, hard to imagine, but just a quick recap of like where you're at and what your practice looks like.
You're too kind, sir. Yeah, I'm an interventional radiologist. I practice at the University of Chicago. I've now been there, about 6 years, which time is flying. I'm in my 10th year of practice, which also, again, is kind of crazy when I think back about it. Have been doing a lot of different things. I'm very interested in all aspects of IR, including oncology, deep venous thrombosis, pulmonary embolism. But most recently now have gotten really excited and really interested by MSK embolization specifically, and started an MSK embo practice, I would say actually about almost 3 or 4 years ago now, when this really, really sort of first came from overseas to the US, and now have built up a pretty good practice, I think, where we're seeing about 5 or 6 patients a week in clinic, and about half of those are turning into actual procedures.
Fantastic. Yeah. And so just to kind of quickly segue into it, how did you first become interested in specifically the topic of today, GAE, genicular artery embolizations?
Yeah, it's good questions. I think I've always just been interested in innovation and sort of the new aspects of IR and kind of what's out there. I think what's really drawn me to GAE, aside from obviously the fact that it can treat arthritis in a very unique and innovative way, is that it truly addresses a treatment gap. I think a lot of what we do, for better or worse, is a competing strategy or a competing therapy. But with GAE specifically, what I think drew me to this specific procedure was that with arthritis, there's not a lot of great interventions. There's medical therapies, there's surgery, and then, there's really nothing in between. And there's a ton of patients out there. We can get into the epidemiology if you want, but there's a ton of patients out there who actually just don't have any options. And so I think what was really exciting about this is that this really evolved to address that treatment gap and really address those patients who have nothing else. And I think that's what's allowed the practice to also sort of really grow really fast.
We touched on it a little bit last time with Mark Little about, what the ideal patient looks like for this. Because like you said, it's not, sometimes it's even just younger patients who have really bad OA. Like you don't want to put an implant in them because they're going to have a repeat implant. at some point. So orthopedics are really happy about this procedure, it sounds like. But for the uninitiated, will you just tell us about the knee OA disease process, kind of, you were saying the incidence and prevalence, and how these patients are typically presenting in your practice?
Yeah, for sure. So when we talk about knee OA, it's a highly prevalent disease. About 15 million patients in the US alone suffer from it. So huge public health problem. It's the number one cause of chronic disability, physical activity limitation in patients. And the way that I think about it also is that it's the number one thing that a quote unquote healthy person sort of experiences, I think, as they grow older. And I think because of that, there's a lot of sort of other negative diseases that are tied to it. Specifically, there's an increased incidence of coronary artery disease linked to knee OA. And there's also an increased incidence of depression, suicidal ideation, mental health consequences, essentially. And again, I think this is all related to the fact that you basically were otherwise a healthy person and now sort of have this disease that sort of prevents you from doing all the things that you used to do. So because it's such a major sort of highly prevalent disease, I think there's a large population of patients that really would stand to benefit from improved therapies, because the primary way that the knee OA is sort of dealt with is with, medical management. And medical management includes physical therapy, NSAIDs, whether it's oral or intra-articular, as well as intra-articular, gel injections, corticoids, hyaluronic acid. And then you have a ton of other therapies that are out there that really actually aren't that well, established in guidelines or accepted. But again, I think for the patient who has knee OA that is suffering, they're willing to try anything. And so that includes a ton of other stuff like acupuncture, like PRP injections, things like that, So when those things don't work or fail, then you have to start thinking about knee replacement. And again, if you going from, getting like a knee injection to a complete arthroplasty, that's a big jump, and that can be very scary. My mom had a knee replacement, so I sort of saw up front exactly what that means in terms of the recovery, the pain, all that sort of stuff. And it's a great procedure, but it's also really, really, there's a lot that's to it.
Yeah, my in-laws both have gone through it, and it is no joke. You're right. The recovery is not, they actually recovered faster from spinal surgery, from fusion surgery, than they did from their knee. You forget how much you rely on that knee joint for just mobility, right? And
right.
How it can be very painful. And so, just to kind of back up a little bit about like how these patients are coming to your practice, are you seeing them in clinic, or is ortho sending them over? Tell us about like sort of how you're building this GAE practice.
Yeah, definitely. I think as I mentioned earlier, I started a long time ago. I think probably relatively, early adoption kind of phase. And so when I first learned about it and was very interested by it, the first people I sort of went to was orthopedics. And they, I think rightfully so, kind of looked at this and they said, we don't really buy this. You're going to mess up our arthroplasties. You might cause ischemia to the joint. So they weren't really terribly excited. And so, that kind of obviously put up a little bit of a roadblock when I first wanted to get this practice going. But, and then I sort of turned towards other specialties that manage OA, because that's another interesting thing about knee OA is there's not just one specialty that sort of gatekeeps this disease. There's actually, because of how prevalent it is, there's many providers out there that are taking care of these patients just because there's so many. I had a very close relationship with my pain management colleagues, primarily because I was doing a lot of oncology work with them in terms of MSK oncology. And so just in our natural conversations, GAE came up as a alternative therapy for OA, and they were performing nerve ablations, and they really felt like that procedure didn't work well for their patient population. And so when I told them about GAE, they got really excited. We sort of set up a study. We got an IDE from the government. We started performing it on some patients. And again, the results sort of spoke for themselves, and the practice sort of naturally grew just from that. And by the time we sort of finished that sort of study, the university had advertised that study. So I was getting a ton of self-referrals. I was getting, every day, maybe a couple patients emailing me sort of interested in the study. And by then I started offering it as standard of care. And, by then, now that I sort of had my own patient base, I found that orthopedics was a little bit more willing because I had some data. I showed to them that I was sort of doing this in the right way in terms of, doing this academically. And one person specifically within the orthopedic department who's a KM&R doctor, who's kind of their non-orthopedic person, was the person that I really specifically collaborated with. And he's now my primary referrer. But I have also spoken with rheumatology. I did grand rounds. And so what's really rewarding about this procedure is now my referrals come from multiple specialties: orthopedics, rheumatology, pain management, self-referrals, and also some family medicine. And even just in the community, just people are Googling and other docs are seeing that I do this and sort of reaching out. So it's great because I don't have just one sort of source that I have to rely on kind of thing.
Yeah. So, I mean, I guess that was the other question I had was, for docs who want to add this to their practice and they're kind of talking to potential referrers like ortho or non-ortho docs that treat OA, even primary care docs, are there any pivotal studies that you can, direct the audience to just say, because, a lot of times they want to hear about the data. They want to know, okay, how do you know this works? Maybe they're not aware. Is there anything that you use as sort of evidence, either part of the discussion or you send it to them later?
Yeah, definitely. I think the data is very important. Again, just thinking about this academically, just pain in general is a hard sort of topic or subject to show beneficial data, if that makes sense. And there's obviously a lot of studies led by some of the prior guests that you've had on the STOAT, including Mark Little and Jafar, who are trying to sort of help push this field forward with the critical studies that they're doing. When I talk to a new doc or a referring doc, I tell them a couple things. One, I tell them, believe it or not, this procedure has been around for a long time. It's actually was first described by Akuno 10 years ago, 2014, I believe. And so this is not some, wild new concept. It's been done overseas for a while now. And then when I start talking about studies, I obviously refer to some of his data because, again, he has some of the largest experience. He has MRI correlative data that shows reduction in synovitis. So we have some imaging correlates or some imaging biomarkers to show that what we're doing actually reduces the synovitis, shows that on MRI. And then I point to some of those pivotal studies related to some of the guests like we've just talked about, like Mark's Genesis 1 study, which, again, recently just published sort of the final cohort with 2-year data, which is obviously really, really impressive stuff. Aside from that, the other data that we sort of like to point out is that the data that exists is not just from one country. I like to point out that we have global data from multiple countries, including the US, Australia, Korea, Japan, England, Netherlands. And all those studies from all the different countries show very similar results in terms of the improvement. So it's been validated in that sense as well. So there's still a ways to go with the data specifically, but I think the existing data is pretty compelling to give a lot of these patients at least a shot to sort of say, hey, you don't have many other options. The data on this is encouraging. It's something that's worth doing.
Well, yeah, exactly. Fantastic. The Genesis one, like you said, is probably a great place to start, right? Since it just came out. So it's the most recent data out there. How did you learn how to do this procedure?
In short, I taught myself, but I didn't do it. I didn't just jump into it, if that makes sense. I did do a ton of reading. I looked at, obviously, Akuto's. I think Sunny Bagla was one of the early adopters in America, and I remember watching some of his lectures. I think I had actually also had emailed him and he sent me a PowerPoint. It was great in terms of helping me sort of just understand the procedural basics. And I do remember the first case that I did, thinking, okay, I've memorized everything, I know everything, but, you do that first angiogram and it's like, it just hits you. You're like, whoa, like there's a lot of little arteries here. But now having done a bunch, it gets really easy, really fast. And again, I think that's just a testament to being radiologists, obviously, and sort of that's in our wheelhouse in terms of recognizing anatomy and variants and things like that. So, but yeah, I wouldn't say it was trial and error, but definitely, it took a few procedures to get, sort of comfortable. So the first few procedures I would say were a few hours long, but then, now we're doing them routinely in 30 or 40 minutes.
Yeah. Well, let's talk through, day of procedure, how you do this. Are you doing femoral access? To start with the access, you're just kind of standard straightforward case. And then we'll talk a little bit about challenges after that.
Yeah, for sure. So, I think I'm lucky that, in our hospital, we actually sort of opened up, it's kind of like an OBL. It's still in our hospital, but we call it the Dialysis Access Center. So we do sort of procedures on a C-arm. And I actually think this procedure is very well suited for outpatient work, if that makes sense. Meaning, these are patients who are essentially getting steroid injections. And so I want to try to make this procedure, at least in my own practice, as close to that as possible, meaning I don't want them to think this is some big, huge procedure. And again, I think one of the ways to do that is I do that sort of in our outpatient center. Those patients come in. Oftentimes I try to convince them to do it just with lidocaine only. And more patients are sort of starting to trust me on that. And the way that we do this is they come in, I consent them, they come into the room, we prep the groin, but oftentimes if the patient's obese or sort of has a hostile groin, I'll puncture the SFA, and where I puncture the SFA really is wherever I see it best. So I don't have to necessarily dig into the groin area. It can be sort of proximal thigh. I access the SFA with a micropuncture set. I advance a wire down just to make sure that we are within the SFA. And because it can be confusing, especially if you're sticking lower, you may stick a small branch to the profunda or something like that. And then I just place a 4 French glide catheter over an Amplatz wire. So no sheath, nothing. I really, again, in the spirit of trying to make this as low profile as possible, as outpatient friendly as possible, I put just a 4 French catheter, do an angiogram, and then at that point it's off to the races. We're just going to go ahead and select whichever genicular artery that seems to be abnormal or seems to supply the region of the patient's pain as well. And again, as we talked about, if you do this enough, this actually gets quite easy, over time. Just, the arteries have a relatively predictable origin, relatively predictable course. And, once you sort of do this enough, you can sort of learn the shapes that you need to make for your microwire to select those arteries. And once I select each vessel, I do an angiogram, confirm that there's an inflammatory blush. And then we aim to reduce the blush. It's very important that we're not embolizing the actual parent genicular artery, as the name seems to imply, which again goes back to why ortho, I think, initially sort of balked at this procedure. So the goal is actually not to embolize the genicular. The goal is to prune the neovascularity that sort of grows in the setting of inflammation. And what that really means is it's a very, very tiny amount of embolic. I think when I first saw Okuno talk about this, he really stresses this and he continues to stress it. And once you start doing it, you understand why, because you have this, we're trained to embolize. When you embolize, you take it to stasis and it requires a lot of embolic usually. This is like everything. This is like the opposite of everything that we sort of traditionally do, which is give a very tiny amount. You do an angiogram, you might still see a little blush and you're still tempted to give a little bit more. But as I've learned over time, really less is more. And it's, again, you have to sort of resist the urge to try to get this perfect, pretty picture and sort of trust that just a small amount of embolic will get the job done. And so once we've embolized all those arteries, we do a completion angiogram. And then I just take the 4 French catheter out. I hold pressure where we punctured for about 5 to 7 minutes. And then the patient goes to the recovery area. We watch them for usually about an hour and a half to 2 hours, and then they go home. And if they were bilateral knee osteoarthritis, then I usually bring them back 1 to 2 weeks later. I just let them recover for a few days, and we can talk about sort of some of the post-procedure stuff. But more often than not, they're in the hospital for only a few hours.
Wow, that's amazing. So it sounds like it's pretty streamlined.
Yeah, we, again, because, a very great practice is growing really fast. We typically try to do 2 or 3 procedures in a day. And I usually I'm in that outpatient center only really in the morning, and I do clinic in the afternoon. So I usually can do those procedures. If we start on time at 8, usually by noon, we can do 2 or 3 procedures and I can go to clinic. So I think we've gotten pretty efficient at it.
And are you the only one at University of Chicago doing them, or are there multiple providers?
Yeah, I think because the way this started, was only getting a few consults at a time. And I really wanted to make sure that I could do enough where I sort of felt comfortable. I'm getting close to the point where I think I'll hopefully have done enough where I can sort of start bringing in some other members and the bandwidth. As the practice grows, I won't have the bandwidth to sort of do all the procedures. So for right now, I'm the only person, but I would anticipate very shortly over the next 6 months or so, I'm going to try to start bringing a few of my partners to help, and especially as we sort of grow and expand into other joints.
Vascular anatomy is always challenge. It can be varying,
Definitely.
obviously. Are there specific microcatheters or wires that you like in those cases, or do you feel like you can get the job done usually with your sort of go-to?
Yeah, again, I've settled into a catheter and wire combination that works really well for me. So for me specifically, and we talked about this a little at Guest MSK, I like the 4 French Glide C2 catheter. I like that angle. Sometimes it helps me actually get into those superiors a little bit better. And then as far as microcatheter goes, I will usually interchange between a True Select and a ProGrade Alpha. And then my wire of choice actually is the Asahi Chikai wire. I really like that wire, particularly because a lot of these cases now I'm doing on a C-arm in our hospital. That wire has a very radio-opaque tip, and I really like how sort of easily I can see it, and it shapes really well as well.
Embolic materials. What do you? I mean, we see different things out there from different vendors. How has that evolved over time since you started doing this procedure?
Yeah, I think the choice of embolic is probably arguably the most exciting part of MSK embolization right now. I think it's the focus, as you know, from recent MSK guest meeting. That's really what a lot of people are talking about is, what's the ideal embolic, how much to give, what are the satisfactory endpoints, how many vessels to treat. And I think the consensus seems to be that the field is moving towards temporary embolics or resorbable embolics. I don't think we're 100% there. And we obviously have some compelling data to potentially suggest that permanent embolics work just as well and potentially may work better, as reported by Matteo and his colleagues with the Gaucho trial. So, but for me, again, sort of going back to my personality, I want to sort of learn and try a lot of things for myself to sort of better understand. So I started my practice doing primarily permanent microspheres, but, ever since Mark Sapoval published the plyo joint study, I've been fascinated by that. And I've switched almost completely to Lipiodol contrast emulsion. And, I think we'll show a case here at the end, but it's been quite the journey with that. There's a little bit of a learning curve to that as well, but I've really enjoyed, sort of doing that. And I think there's some particular advantages to that, again, we can talk about, but that's what I've been doing most recently.
Do some of the embolic materials have a learning curve to them where maybe it's good to start with something that you know and are used to if you're first starting out?
Yeah, that's a great question. If I look back, I would probably suggest to people, especially in the United States, to do microspheres. And I think partially because, that's what's FDA approved for embolization, and so I think you have some sort of comfort there using an embolic that's on label for embolization at least. And, I think that sort of resonates with patients a little bit for that reason. And then I think, like you mentioned, we're very comfortable using particles, obviously with, PAE, UFE, tumor embolization, things like that. So the learning curve there is much shorter. And again, as we talked about, it just takes a very tiny amount of embolic. And then I think if you get comfortable with that, going with like Lipiodol emulsion or even imipenem, which is available in the United States, it can be done. I think, and I think there's some particular advantages in the sense that you can go to stasis. You don't have to worry about reflux and all these sorts of things. But again, I think there's other reasons to maybe consider not doing those just because they are sort of newer. There's less data, all that sort of stuff.
You do a fair amount of PAE as well, right?
No, I actually don't do much PAE.
Okay.
That's the one frontier I haven't explored.
Well, no, I was just going to ask that maybe because, a lot of people who are maybe doing PAE in the outpatient space might be interested in this. I was really curious about like the level of difficulty, because you hear about PAE being challenging with varying anatomy and so forth, and especially with big prostates. What would you compare this to in terms of level of difficulty for somebody who's just starting out?
Yeah, that's a great question. So I think maybe that's partially why I probably subconsciously not really explored PAE very much. I think PAE is one of the hardest procedures in IR.
Yeah.
As you mentioned, the artery can be very small. The origin can be incredibly tortuous. The few PAEs I've done, I talked to my good friend, Nayan Parikh. He's one of the giants also in that field. And, and I'm always amazed how intricate that procedure can be. And the reason I say all that is because I think GAEs in a lot of ways is the opposite. And I encourage every IR, that's listening, that is sort of looking for a niche, that GAE is a really good niche, I think, to pick up because it does help a lot of patients. there's a lot of patients out there that need this procedure. And then also just from a technical standpoint, I really don't think it's a hard procedure. I talk to a lot of people who are doing this, and we all sort of share the same sentiments. Yeah, maybe the first few cases are difficult, but after that, you really settle in. The arteries are very reliably seen, and you can start doing these procedures really, really fast.
Okay, fantastic. And so, the thing that everybody's always worried about is what kind of complications do we want to try and avoid here?
Yeah, definitely. I think because, again, we're sort of in the infancy of this procedure. It's really important that we focus on safety. And I think as an academic, that's something we think about a lot. And I would encourage people to think about safety, especially with a procedure that's new, that's not completely validated yet, and where there's some skepticism outside of our field about. So the way to sort of, I think, ensure safety is to really, be meticulous with your technique. And particularly, I think where docs will run into issues is with over-embolization. So I think, again, really cautioning people to be using a very small amount of embolic. And when I say small, we're talking 0.2 to like 0.5 cc's. And I've seen some lectures from Akuno, for example, where he said, if you're using more than 3 cc's in a case, and he uses imipenem, which is a temporary agent, or at least primarily used imipenem. If you're using more than 3 cc's in a case, you really need to stop and think what you're doing, meaning, making sure that you're not having some shunting or reflux, or, you're not seeing anything like that. And even, just a call to our own data, our study showed that I think if you used more than 2.5 or 2 cc's of embolic, the rate of skin discoloration and sort of transient pain really increases a lot. So if you're using more, it doesn't mean it's wrong, but it will sort of potentially portend more complications. So I think that's really the main thing. And then the other thing I would say is really, as we sort of talked about earlier, really learn your anatomy, rely on your expertise as an interventional radiologist to sort of know what the vessels are. There's a lot of overlapping vessels that essentially treat completely non-target areas, and you can get fooled relatively easy, especially early on. So if you have access to intraprocedural cross-sectional imaging, like cone beam CT or angio CT, I would encourage you to use that liberally until you get very comfortable with this procedure. So I think those two things hopefully will keep you out of trouble.
Yeah. I was talking to a doc recently who's in the outpatient space who had a couple episodes of like skin changes around the knee, and, it kind of freaked him out a little bit, got Sunny Bag on the phone, kind of figure out what to do. Any advice for that? Is that something to be expected on, especially early days?
Yeah, definitely. So I think that's another great point is expectation management. I think just going back to the efficacy of the procedure, when I talk to patients, I tell them, look, this is not a cure. At least the literature doesn't suggest this is a cure. We're going to improve your pain about 50%. At least that's the sort of goal. And we're going to achieve that in the majority of patients. And then when I talk to them about complications, I say, the side effects of this procedure are that invariably there are tiny branches that go to the skin, and invariably the majority of our patients will get some transient skin discoloration. Now with microspheres, that's going to be much more common. And again, even if you use a small amount, everybody's going to get some, what looks like sort of light bruising around their knee. And if they sort of know that, they don't freak out, you won't freak out. And 99% of the time, almost probably actually 100% of the time, at least for me, fortunately, by 1 month, it's all gone. So as long as, they sort of know to expect that, I think that they're okay with that. This can obviously progress to ulceration, things like that. So it is important that you follow those patients up and sort of make sure that that doesn't happen. The other sort of part of expectation or symptom management is you, more often than not, the first few days, patients will get increased pain. And I used to give everybody a steroid pack. I used to tell everybody, give them narcotics or whatever. And I think I've found that if you tell them you're going to get skin discoloration, you're going to get increased pain, it's going to last for a couple of days. They sort of know that, they sort of expect it. And after that, they don't really need anything. And so I can actually just manage them with just sort of even more conservatively. Don't even need to give them any additional pain medications outside of maybe like a Tylenol or something.
Got it. It reminds me of like early days Y90 where you put like the ice pack over their, belly. You ever do that over the knee?
Yeah. Sorry. So yeah, that's the other thing. You brought up a good point. So yeah, we also put ice packs. Again, like you said, just like the Y90 sort of correlate with the falciform. I don't know if that's actually doing anything. It might be just treating us, but It's such a low risk thing to do that, we still do it for all of our patients, can't hurt kind of thing.
Right. Constricts the blood vessels at the surface. So maybe it minimizes, skin changes. That'd be
Correct.
interesting to see if anybody does a study around that or something.
I have a nice angio CT actually of like a descending genicular where you can see vessels going to the joint, and then you see these tiny little arteries that you couldn't see on the angio going to the skin, but then we have our ice pack like right over it, kind of, right on the side of target. But again, I don't know how much it's helping or doing anything.
Well, Oz, anything else like post-procedural or any kind of tips or tricks as we're going to go over these cases here in a couple of minutes, but anything else that you want to, that's essential, I think, for, people starting to do this?
Yeah, definitely. If I could make a small little plea or pitch, I think, again, this is an easy practice to build, because there's so many patients out there that need this type of therapy. I encourage people to try to do this academically, meaning really try to follow your patients, really try to record the data. We're working, I think, tirelessly to try to get registries open, try to get sham studies in the United States going. There's other giants in our field in America like SYNPOSIS who are also doing this. And so when those opportunities show up, we're hoping that people that are out there that are sort of capturing this data can hopefully sort of join in, whether they're in academia or in the outpatient space or anywhere in between. And then I think, just as far as tips and tricks go, I would encourage people to sort of, now enough people are doing it that you can get, advice and recommendations from a multitude of people. And everybody that I talk to does it a little bit differently. I think, one big difference, I think, is a lot of people do retrograde pedal approach. And I think for the PAD experts out there, that's an easy sort of a transition to do that. And obviously patients probably prefer that as well. For me, I've found that the anatomy is a little more difficult and a little more complex to come that way. But again, I think I encourage people to sort of talk to people to figure out what angles work best for them.
Yeah, I was going to ask you about that. Have you ever considered that? The typical, pedal access, of course, you're worried about like the outflow of the foot, but if they don't have any peripheral arterial disease, they got a healthy dorsalis pedis, it seems like a short way to get there. But yeah, the angles could be kind of tricky.
Yeah, I found that I've only done it once, and maybe that's why. But when I did it, I found that the angles were more difficult. It's actually longer, believe it or not, than coming from the SFA. So that was another thing. I found that like my catheters barely reached. But again, that's the beauty of IR. You talk to anybody who does like a perm cath, we all do it differently, but we all get it done. So it's like, I always tell my fellows and trainees, like, again, as long as you do it and you do it right, and the patient has what they were supposed to get, and you didn't take like 6 hours doing it, I'm happy,
There you go. Especially for a perm cath.
Yeah. Well, 5 hours, that's okay.
Yeah, right. You just posted a shoulder on Twitter, I think, the other day. Also very cool. It's just amazing that what we're seeing.
It's amazing. I tell people when we talk about this, I feel like the knee is Pandora's box. Like I'm very focused on the knee. It's a very prevalent disease, but also a lot of the data is there. And I think if we work really hard as a specialty to try to validate this intervention, I think that then opens up the door for all these other therapies like, adhesive capsulitis, plantar fasciitis, all these, basically sports injuries, soft tissue injuries, all that sort of stuff.
Yeah. So are we seeing more docs doing that in the U.S.? I know, Mark's been doing it in France, but are we seeing it catch on, even around the world?
I think it's slowly starting to catch on, or people are, I think most people, this is not why I post it on Twitter. I just post it because I like to post interesting stuff, but people are reaching out and saying, oh, that's really cool. Like, why are you doing that? People don't know the data as much, obviously. And so just sharing the study with them, people are very intrigued and interested by it, but I'm trying to work with Guerbet to hopefully try to do some US-based studies to hopefully help validate, the important work that Mark has done, and try to get it, hopefully like an on-label indication for that here as well would be awesome, because I do think there's a lot of advantages to it.
Fantastic. Well, Oz, once again, thank you so much for coming on and sharing your expertise and these cases. If anybody needs to reach you or has any questions, is there a good way? You're on Twitter, obviously?
Yeah, definitely. No, first of all, thanks so much, Aaron. It really is. It's amazing that you continue to invite me back here, despite all the, all the nonsense that I say. But I appreciate it. And yeah, people can reach out. However, my Gmail is pretty easy. It's Osman, OSMAN 1423 @gmail.com. And then I think, as you mentioned, I'm pretty active on social media, so you can always message there as well. The real Dr. Oz, OS, not OZ. But yeah, I'm pretty accessible, so feel free to reach out anytime. And I love talking about this stuff, as you probably know. We could talk about it for hours.
Yeah, exactly. Well, perfect, Oz. Thank you so much. Thank you to our audience for listening. We'll catch you next time.
Thank you, Aaron.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
And Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jimroy Kennebrew.
Thanks again, and see you next time.